This is a very interesting article. It's not about opioids, but I'll offer it as sort of parameters for how we might do things a little differently. This is Schiff and Glanner and JAMA 2009. Think beyond drugs. I mean, if we have this condition that is as much as 80% emotional, thinking that we're going to get ahead of it with a medication is unrealistic. So think beyond drugs, physical therapy, motion. Practice more strategic prescribing. Get that projected idea of where it's going to be a month from now, and 2 months from now, and 3 months from now. Heightened vigilance regarding adverse effects. Talk to your patients about what's happening. Get a bone density test. Get a testosterone level in your name. Caution and skepticism regarding new drugs. And lastly, shared agenda with the patient so that you have an ability to really communicate with him or her when you're getting started. And then weigh longer-term, broader effects of drugs. There are problems doing this. There are barriers to conservative prescribing described in this article. The first one is time pressure. I mean, it takes 5 minutes to say yes, write the script, and move on to the next patient. How long does it take, and what's it like to say no? It's pretty daunting. It really is. There are income bonuses linked to patient satisfaction in many systems. Judge Tatro was saying that. Okay, so income bonuses. I have a friend who works for a managed care company in San Diego. He just went there, and he took over practice of a hyper prescriber. And they knew it. And he's young and he's energetic, and they said, we want you to sort of bring people down off their meds and decrease the amount of consumption of morphine equivalents.
And improve their satisfaction.
No, he's not going to get a bonus next quarter because everybody hates him. I mean, you know, that's a true story. I mean, it's not the only part of the story, and he pretty much has, you know, sort of this philosophy of treatment, and I spent a lot of time with him to say, I'm going to do this anyway. And interestingly enough, he's been there about 8 months, and people are starting to come back and say, thank you, doctor. Nobody ever said that. Nobody ever said, try cutting down.
It's how much are, what's their level of knowledge or understanding based on advertising, based on information they've gotten from there?
Most people who come to treatment, there's 4 kinds of people. It's on the next slide later on, but I'll say, okay. No, it's okay. 4 kinds of people. People who have addiction, they know what they're doing, they know they're in trouble, they want help. Some of them were addicted previously, some of them got addicted because they had a painful condition. And they know they're in trouble. We have a whole big percentage of people who really don't identify as an addict. These are some of those that are in your practice, where they simply take their drugs as prescribed, but their life is not going very well. They don't think they can live without their opiates. They really sincerely don't think so, but they want to try.
So they take them as they're prescribed, but you've got to prescribe.
Yeah, well, they're dependent on them.
Right.
If they begin to escalate the dose because of tolerance, what they find is that they're running out early. Some of those people will go to the street for the drugs, most won't. We used to call that, there was a pharmacist, sorry, but who created the term pseudo-addiction. You know, acting like an addict to get drug, and if you create enough of the drug in their system, the pain will go away, they'll stop acting like an addict. Well, that is not what happens to those people. They just escalate their dose. Some of the people in that second group who don't identify addiction think everything's fine. Those are the challenges. Those are people that come as a result of a professional interventionist, you know, a family who hires somebody who comes in and says, you either go to treatment or you can't live here. Or a physician who says, I'm not prescribing anymore, go over, see Pohl. Or a workman's comp company that says, we're not going to pay your disability unless you get a trial at getting off meds because 10 doctors have said you're abusing your medication. And that person comes in angry, really angry. So different approach to different people, but I start out the same way. I am going to take you off all your medications, and when they stop screaming and saying, what are you, crazy? I'm going to take you off all your habit-forming medicines, and your pain's going to get better. That's what I tell them. And they don't believe me. So then I send them out into group with 10 people, 8 of whom have done exactly that. Came in disbelieving, hung up their cane, out walking, doing core exercises, and having less pain.
Every group has the same response, they don't believe it?
Pretty much. Some people will say, I thought something like that, but it never made sense. And then I'll spend quite a bit of time talking about hyperalgesia, and I'll explain the physiologic basis for it. I'll also talk a little bit about emotions. And, I had a woman who came into my office, and I told her the story, and she said, are you telling me my pain is in my head? I said, well, where else do you think it is? She said, it's in my back. I said, but the doctor said your MRI is normal. So how is it that you're paying? So, but, I mean, I'm kind of irreverent with my patients. So I'll give them a little, because this is so serious. Their life is at stake. And really, they're living every day without joy in their life when they're on opiates.
So you mentioned pseudo-addiction as if it didn't exist. Is that your opinion on it? I'm just curious.
I don't know if it exists. It makes sense that certain people have an exacerbation of illness. For whatever reason, their pain goes up. But the key for pseudo-addiction is you get the right pain control, and that's it. And my experience, and maybe it's a skewed portion of the population, I think people get relief for a while, and then they get tolerant again, and then it comes up all over again. And I have my bias against pseudo-addiction. I used to diagnose it all the time, because the psychiatrist would call me in a psych hospital to see the psych patients who also had addiction. And it was all pain, and they all wanted pain meds, and I diagnosed pseudo-addiction, they just give them more drugs. And then the psychiatrist would call me back and say, we don't have enough drugs to take this person out of their pain. So I think that it's probably a small percentage of people have it, but I think it's overdiagnosed. Okay. Industry-funded research. So that's that whole bias about placebo-controlled studies and stating that, industry isn't going to publish a study that says that the drug works as good as a placebo. They don't. That's not what they're aiming to prove. They're aiming to sell their drug. And last is ethical qualms about withholding adequate pain treatment. So they say you can't do a controlled study if you withhold this, legitimate treatment. So what do we do to control? Primary prevention, preventing new cases of opiate addiction. Secondary prevention, providing people who are addicted with effective treatment, including buprenorphine or abstinence-based treatment. And then supply control. So this is law enforcement. This is where pharmacy monitoring programs come in. This is where going after doctors who are running pill mills, who are overprescribing with no intent of doing adequate assessments. And lastly, dealing with the black market. Opiate prescribing rules. If you're prescribing opioids, require screening for addiction before and during treatment. Require screening for depression before initiating treatment. Requiring a physical exam and a documentation that alternative treatments have failed to opioids. Require urine toxicology for all patients receiving long-term opioid therapy, and set dosing limits to prevent high-dose prescribing. We know that the problems start over 100 milligrams morphine equivalent. If you're heading in that direction, you ought to be very vigilant and really try your best not to go over that. And lastly is mandate this kind of training for people in pain and addiction. Entry strategy should consist of some screening tool. You can do this in your office. Anybody use screening tools, SOAP or KJAID, 4 questions, the ORT or the DAS? This ought to be a part of every practice that prescribes. This is a self-administered questionnaire that puts you on a bit of alert. Now, Gourlay and Haidt wrote an article called Universal Precautions in Opioid Prescribing. And the standard of practice is just like with infectious disease, treat everybody as if they have a potential problem. And be judicious in your prescribing. But if you do these screens, that's one of the things you can do to really heighten your alertness to potential problems. Not looking at the person and saying, oh, that little old grandma can't be an addict. She can't be selling her drugs to people down the street to pay rent. That couldn't be happening with my patient. Psychological, psychiatric screening, awareness of chemical coping styles, and family history of addiction also help in that process. The entry strategy, one of the things about entry strategy is you really should have somebody else in the room to corroborate the story. So collateral information from spouse, friends, family, medical records. It's imperative to get medical records on past use. Pharmacy reports. In our state, we have wonderful pharmacy monitorings. How many people query the data bank before you prescribe? Oh, great. That's great. We're ahead of the game on that. Isn't that great? Nevada is actually ahead of the game nationally in prescription monitoring. Of course, they can go to California and get drugs, and you wouldn't know that until the systems are linked, and that's coming. Urine drug screens, presence and absence of drugs, and then a conversation about how are we going to know if this trial is working. And I think that's probably where we might need more help, to have a conversation and say, here's what I'm going to do, here's how long I'm going to prescribe it. If you come in a month or two and your dose is up instead of down, or your pain is up instead of down, this is a failed trial. So we're not a year or two down the line. We're 6 weeks in. and we say, remember this conversation? Now it's time to go off the opiates because they're not working. Look, your pain's where it was when we started them, and now you're having some side effects. And that's when we ought to take them off. Everybody ought to be having a signed opioid agreement in the chart. There's no real evidence base that it helps, but it does set out the parameters of what you're going to do with that patient. And this is just one. They're available online. People use them in their practices. Okay. Monitoring. 5 A's. Analgesia, affect, activities of daily living, adverse effects, and then aberrant medication-taking behaviors. So you really want to be on alert for people who are escalating the dose without permission, people who are coming in and saying, you know, that generic Vicodin doesn't work, I need brand name Dilaudid, 4 milligrams. That's the only thing that's going to work for me.
It sells much better on the street.
It sells much better. Of course it does.
Well, that's what I found too, is patients ask for specific types, like
That's an aberrant
Soma.
behavior.
Soma, they want the Danbury brand because it has Dan on it, their Dan's on the street, and that's what they get the most money for.
Be alert. And then there's people who are writing their own prescriptions. You know, keep your prescriptions under lock and key. They're taking one of yours and they get a computer, and now you're writing a lot of prescriptions for other drugs. Aberrant use includes chewing drugs that are meant to be swallowed, snorting drugs that are meant to be swallowed, and the like. This is a result of a urine tox. This is 938,000 urines, and this is the incidence of abnormals. So if you're screening urines, you're going to find that some people are having illicit drugs, which is against the rules. Some people are having non-prescribed medications in their urine. Some people are having prescribed medication not present. Where is it? It could be it's all in their medicine cabinet. They didn't need it that month. Or it could be that it's out on the street being sold. And then,
Or it could be, as I think happens with that theoretical under treatment, that they took it all in the first 2 weeks, and by the time they get back to you,
yeah.
yeah.
So, you know, urine at least deserves a conversation, at the very least. And then there's the exit strategy. Discuss options, continuation of the conversation on entry, be consistent, supportive, informative, please, non-judgmental and firm, and not punitive. I mean, I can't tell you how many people call me and say, I got a bad one in my office, you got to take him. You know, that's not what this is about. Even if it's addiction and abuse of the drugs, people are doing what they know how to do to treat a condition that they've been treated by you for quite some time. So firm, strict boundaries, refer to the agreement, but not punitive. Gather resources for support in their family and support system, and then discuss detoxification options. And this is a tough one. If you've got people that you've decided need to come off these drugs and they're physically dependent, you're going to have your hands full, because weaning off these drugs is really hard. Because when they're weaning off, they're in withdrawal, and when they're in withdrawal, their pain goes up. We see that. Our withdrawal lasts about a week to 10 days on an inpatient basis, and they get a lot of support. I mean, if you have in your practice and you're doing it over 4 to 6 weeks,